So imaging the cornea with our smartphones. So we've talked a lot about using photographs as a clinical tool, not just as simply as documenting a single problem. So questions which we ask about the cornea particularly are, is it reflective? So if it's reflecting light, that tells us the anterior corneal surface is healthy. Second thing is it transparent? And transparency tells us that the corneal stroma and the inner lining of the cornea is hopefully healthy as well. So opacities on the back of the endothelium or within the stroma will affect transparency. We also can ask the question, are any opacities in the cornea of visual axis significance? Are they likely to affect vision? We can make an estimate as to depth. We can estimate the curvature of the cornea or the effect of the lesion on curvature by taking oblique views, particularly by looking at the profile. And the techniques we're going to use are distant direct, which we would use with a ophthalmoscope at 0 arm's length. We've talked about mimicking that with the iPhone, with our phones, and also what we call close distant direct. So getting as close as we possibly can, rather than distant technique, as close as we can with the phone, but still having the light on and then filling the screen. We can add in a macro lens to look at small lesions and use lighting either obliquely or by retroillumination to highlight lesions. And to help to confirm their transparency and their reflectivity. And also by changing camera angle, we can make comments about the effect on the corneal curvature itself. So deep ulcers, it's all about getting a good angle, getting a nice, with our photographs, getting a nice oblique view of the cornea, highlighting the lesion at the top of the curve of the cornea, and using that to estimate our depth. Then look for stromal infiltration, which is very important in deciding how serious corneal disease may or may not be. Knowing whether it's transparent or opaque is very important. Subtle corneal opacities, such as anterior subepithelial deposits we see in multifocal punctate keratopathy, can be very difficult to identify, but using good oblique lighting we can identify and record them. Also subtle changes in refractivity, which we see in with linear keratopathy lesions and Harb's striating glaucoma. So this is some examples of some of the photos we can get. This is a macro, on the left is a macro photograph of the front of a horse's cornea, and it's beautiful blue, purple, yellow, rainbow type image we're seeing here is where we focused on the anterior tear film. And this is actually lipid, which is sitting on top of the tear film. We can see a beautifully reflective cornea. We can see the upper eyelashes reflecting the cornea. We can see the lacrimal lake. So this is where the tears sit between the lower lid and the cornea, and that's where they're stored, if you like, between blinks. So we can say lots about the health of this horse's tear film from this single photograph. We can make more comment on tear film by adding in fluorescein, and fluorescein can stain the tear film, make it brighter, particularly under a blue light. Adding in stacking our images. This is stacked macro photographs rather than a video. It looks like a video, but they are stacked macro photographs. Can again give us even more information about the quality of the tear film. The shimmer tear test we do in the horse, but actually this sort of assessment, we're actually looking at the anterior cornea. We can see this, you actually see the tear film moving around, see the intact meibomian lipid. Is more useful in many ways than the absolute tear volume, which you record with a shimmer tear test. So macro photography of the anterior corneal surface and assessing the tear film is very helpful. Another stacked image, again illustrating the dynamic tear film, the dynamics of the tear film. It's the lower lid, the limbus, and this is the lacrimal lake. And you can see as we move backwards and forwards, it's like the tide coming in and going. But the point of the photograph is partly because it's beautiful, actually is to document this this iris lesion here, which you can see has a typical carpet-like appearance, and it's just starting to affect the iris architecture. And this is very typical of an early iris melanoma. So we talked about the question you want to ask: is it transparent or not? And the tool we use to answer that question is distant direct ophthalmoscopy. This is a horse with fungal keratitis who's had a conjunctival pedicle graft. One of the few indications we have in the horse nowadays. With the light off or on, we can look at the transparency of the stroma next to our graft and start to gain the information as to whether we need to worry about fungus growing back into that adjacent normal cornea. We can add further information by retroillumination, so we're shining a bright light in at an angle, bleaching the left-hand side of the photograph. But as the light bounces back, we can actually see how transparent the conjunctival graft is. And we can see through the conjunctival graft to the corneal stroma beneath it, and actually see that there's no corneal stromal opacities. All we're seeing here is the graft itself. Another similar case, another fungal keratitis with a conjunctival graft, and again we can see by just changing our angle of a light that we can actually see through this graft. You can actually see the pupil going through here, which gives us a clue how thin this graft is, and allows us, by seeing through the graft to the stroma beneath, to know whether we're likely to have recurrence of the fungus. That previous photograph was taken with distant direct, but just zoomed in, and we can do the same thing with a macro lens. This is a macro lens, focused on the lens, on the graft itself, with retroillumination, top or bottom, to try and show us the transparency of the graft and the underlying stroma. With our macro lenses, allows us to look at great detail. Another really important part of the horse's eye, a part we don't look at enough, which is the drainage angle. This is the grey line seen nasally and temporally in the horse's eye, and the grey line is the insertion of the pectinate ligaments. You can see here traversing the drainage angle from the base of the iris to the edge of the cornea. So this is a beautiful part of the eye, and a part of the eye which is easily damaged, both in chronic uveitis and in blunt trauma. So again, we have the edge of the pupil, the iris itself, the pupil zone, the ciliary zone, and then the insertions of these beautiful pectinate ligaments going up to the inside of the cornea, and then you can see through the cornea, through the grey line, actually into the drainage angle itself. So it's the way we photograph these is by using the macro lens and having an oblique light coming in to highlight the pectinate ligaments. We can also, by changing our angle, actually look down into that drainage angle, and again, this is a very good place to look for very subtle changes in disease like chronic uveitis or post-trauma. Imaging the iris itself is a beautiful place to explore. It's like looking at the surface of the moon and one of the other planets. And there's different ways of looking at it. We can use a close-up view by using without any fancy lenses. Just using digital zoom to get the eye to fill the whole, the whole screen. As you have this left up image to highlight the iris cyst, and we added in coaxial lights. It's effectively distant direct, but we've zoomed in, so close distant direct, which allows us to comment on the effect of that likely effect of the iris cyst on the visual effect of this visual field in this eye, and using macro lenses we can use to actually look at the surface itself to look at another iris melanoma. When we use the phone, is you can just also take videos. So in this iris cyst here, we're doing what we call the wobble test. So we're using distant direct, zooming in to get the eye to fill the screen, and then we're wobbling the eye through the upper lid to try and look at the effect of doing the same here with other cysts, trying to look at the effect of movement on mobility of this cyst. So you can see this lower cyst here isn't moving very much. with when the eyes gently wobbled, and this upper cyst here is moving. You can see it moves up and down at a much faster rate than the granular iridica. So it wouldn't be surprising for this horse to be aware of that cyst in a way it wouldn't have been with this granular iridica. So we're using we call this the wobble test, a way of dynamically assessing the likely effect of a cyst in an eye. So again, we've met this beautiful picture of this iris melanoma before, and this is very useful for being able to monitor these lesions. It's often difficult to differentiate them from iris nevi or freckles. One on the left, I'm very happy the centre of the lesion is starting to become mounded and obscure the iris architecture. Here we can still see iris architecture through all of that lesion, but I'm very suspicious this right hand lesion is on its way to becoming an iris melanoma too. Using oblique lighting and macro lenses, we can also pick up, this is all just with my iPhone, we can pick up interesting pathology. This is a horse who's got a type of uveitis we call heterochromic iridocyclitis. It's a part of the spectrum of disease we refer to as equine recurrent uveitis, probably. And we see chronic uveitis, so you've got shriveling of these granular iridica. We also see depigmentation and of the iris stroma, which you can see along the pupil margin and adjacent to the anterior granular iridica. So we can tell you another story showing how photographs we can use them clinically. This is Sapphire. Sapphire came to us with melanomas in her eye. She's a grey horse, and this first photograph was just taken with digital zoom. So we have the light turned on, and we've just zoomed in to get the eye to fill the screen. So no macro lenses, and we can see the pupil, we can see the granular iridica, we see a lump dorsally and one ventrally. We then used our slit lamp. The slit beam here comes through the cornea, goes across the surface of that bottom tumour and up to the iris margin, so we can tell that lower tumour is in contact with the cornea. Now, to further explore what these look like, we'd use the slit lamp, but we can also use the macro lens and oblique lighting. So this is the dorsal iris melanoma using a macro lens and oblique lighting, and you can actually start to see the anatomy of that tumour beautifully. In the same way, we can continue using our cameras intraoperatively. This is during surgery. We've done a sector iridectomy. We've actually removed both the piece of the top part of the iris and the bottom part of the iris, including those tumours, and we've actually looking down the microscope, operating microscope with our camera to get this image. You can also get a system with another phone to use digital zoom to go actually look at the same surgery. So we're using the camera in lots of different ways to document this horse's story. And again, this horse back in the stable is being monitored by the team, and we can use distant direct ophthalmoscopy to highlight corneal opacity, and also to actually see here the missing iris and the edge of the lens. You can also see some very subtle lesions. So just right in the corner of this is the edge of the lens here. We zoom and we can actually see a small cataract forming. But that was adjacent to where that larger tumour was sat next to the lens, and the heat of that tumour was enough to cause a small focal cataract. We carry on using our phones after the horse is discharged. So the horse is now back home. The owner is regularly sending us updates of the horse, even when they're not in the clinic. And with a little bit of training, they can take really good, clinically useful photographs, which help us to monitor these horses once they've gone home. That brings us on nicely to imaging the lens. One of my favourite photographs here. This wasn't taken with an iPhone, actually. This was on my digital SLR. This is a horse born without an iris, aniridia. You can see the edge of the iris here, the ciliary processes, and the sonules linking here, holding the equatorial lens. So, excuse me, this is a dog, not a horse, but it's a good example of how we can use the camera in different ways to assess pathology. So we're starting off, this dog has had an anterior uveitis. We've got dyschorrhea. We've got the iris is stuck down on the lens surface, and there's bits of iris debris scattered across the anterior lens capsule. We've used a macro lens and oblique lighting and modelling lighting to highlight the pathology at the anterior part of the iris. Next, we're going to use distant direct. We're going to turn the light on and zoom in to get the eye to fill the screen. And now we can start to see past the anterior iris changes. So the black iris rests are now the shadows. That's why they're black. And we can start to see opacities in the lens behind it. So we can see some small cataract formation. If we alter the angle of ourselves or the patient, we can actually start to see, as the eye rotates away from us, we can see these lens opacities become more obvious. If we rotate even further, we can see these anterior lens opacities are more and more obvious, and now we can see posterior lens opacities appearing. So if I rotate back again, the posterior lens opacities disappear, and then back the right way, and they will reappear. So this is how, by changing angle, we can work out where within the lens various opacities are. This is another background patient. This horse has had a corneal transplant, a CCT, to repair a penetrating wound in the cornea here. Some scarring, but largely transparent. It also perforated its lens, and at the same time, so had both its cornea repaired and its lens replaced. And taking photographs from different angles allows us to get much more information about the likely effect on vision and the progress of the case, rather than a single image. And this top right stacked image shows you quite nicely how we can get a lot more information with these multiple images in a single one. This is another similar case, actually. This is another lens perforation of blackthorn. And again, lighting in different ways. So you can actually see the lens capsule tear, the artificial lens in the bag, and the cornea itself. And by changing angle, we can see, we can get information about the corneal curvature. This is a before and after shot. The left-hand one is not long after surgery, where the corneal transplant is still fresh, and this is now several weeks down the line, where the cornea has become nicely integrated. Same eye again, using our iPhones, distant direct. So different case actually, but similar. Different case, but similar pathology. We're using our iPhones with the light turned on, zooming in to fill the screen, and actually allowing us to get this beautiful image to highlight the intraocular lens. You can actually see the anterior lens capsule tear here. This is another perforation which we made into a small capsule rexis to place the artificial lens. And then using our macro lens, we can actually look at the IOL itself, the intraocular lens, and see individual cells starting to aggregate on the back of the IOL. Again, using distant direct, we are looking at another lens case, and we're using stacked images to allow us to look at how this moves in the pupil. So these little tiny bubbles we're seeing here are very typical of lens vacuoles, and depending on their location and size, they may, in some instances, point towards progression of the cataract. There's another cataract here, which is distant direct ophthalmoscopy. We can see opacities within the pupil itself. With a single image, it's quite difficult to know where they are. This is a slit lamp image of the same eye. The left-hand line is the cornea. Then we have the anterior lens capsule, and then the anterior cortex. So these opacities are these sort of shell-like opacities are in one single layer, so lamellar cataract. Much more useful, those single images and the slit lamp, which we don't always have, are these stacked images. So it's a similar sort of case where we have an anterior cortical cataract. We're taking stacked images with distant direct, and we can see as it moves around, we can see how these move relative to the anterior part of the lens, to allow us to reconstruct in our minds this is an anterior cortical cataract. And then the right hand screen, we have a posterior opacity, which you can see is moving relative to the pupil as we move.